Good intro there, Susie. We are really fortunate tonight to have this stellar panel to walk us through what I think is the unconscionable decimation of the Medicare Trust Fund, which is all of our taxpayer dollars carefully earned throughout our working lives, which in turn fund our healthcare, Medicare, once we reach 65, which is often retirement. And that ensuing chapter of our lives tends to be when we need healthcare most. And a number of years ago, when I was looking at all the data, but not that many years ago, 80% of all healthcare dollars in the US were spent during those years 65 plus. So it's a big deal. We need to be at the forefront doing our all to ensure that this decimation of that trust fund stops. And therefore, the title tonight of Reversing the Privatization of Medicare, because the reason Medicare is being decimated is because little by little, more and more private health insurance companies are figuring out how they can get a piece of this more than $1 trillion pie. And you know, when there's money involved, they can be very clever at that. So tonight we are going to meet first Deborah Dahlman, who will be the consumer as she walks into this. And so like thee and me, she's going to start from where our brains are and what we know about this. She's a retired high-tech executive. She's also the current chair of Healthcare for All California, something that she helped initiate. She's a member of what we all call PNHP, but it's the Physicians for a National Health Program, which I think is the stellar organization nationally and definitely in California for understanding why we need a single payer Medicare for all healthcare system. And they are the leading edge people being very vocal about this in ways that summarize at a high level way that you and I can understand, as well as legislators can understand. Back to Deborah, she is doing more things too. So she's been a member of PNHP a good while, and it's also relevant for this, a member of the Movement to End Privatization of Medicare, which is the title we gave to this. Deborah is going to speak first, and then she's going to turn it over to David Leibowitz, who is a retired physician, having done several things, well, really very many. So he ran a lab and was in clinical practice for 20 years. He is a hematology oncologist, and then he practiced hematology and oncology, recently retiring in 2019 from what we all know, the Palo Alto Medical Clinic, PAMF. He was professor, I'm doing this backwards, David, I'm so sorry. He was professor of medicine and of medical and molecular genetics, how about that, at Indiana University School of Medicine. So talk about knowing what he's talking about. And he now lives in San Mateo, so in our fair county. Thank you, David, for being here. Then he will turn it over. David's going to talk about, let's see, we'll start with Medicare. David will talk about Medicare Advantage, which was step one into decimating the Medicare Trust Fund. And then he will turn it over to Anna Malino, who is the national expert. Anna is also a physician, a retired professor of pediatrics from UCSF. She is past president of this PNHP, Physicians for a National Health Program, and she is the lead organizer for the movement to end the privatization of Medicare. You could not have a better panel in the whole country, I promise you. They will turn it over one to another. At the end of this, they will also tell us what we can do, and we are the only people who can do it, to stop this privatization so that we end up with Medicare being able to take care of us. I sure want that. Over to Devra.
Okay, can you see my screen? Okay.
Perfectly.
All right, very good. Well, Elsa, thank you for the wonderful introduction. And we really appreciate being able to come this evening and talk to you about something that's close to all of us. I believe in healthcare. Healthcare is a human right. Everybody in, nobody out. I started fighting for single health care in 2016. And in 2022, my husband and I became eligible for Medicare. And I'm just trying to forward my screen and it won't let me do that.
I had the same problem this week. So if the scroll bar in the middle of your
here.
mouse, yeah, there you go.
Yeah, I found it. Thank you. Okay. I wanted to say in 2022, my story is my husband and I became eligible for Medicare, and with subsidized medical benefits from my previous employer. Our option was a Medicare Advantage plan through United Healthcare. So we signed up, and that's when our Medicare nightmare began. United Healthcare started calling us both twice a week, asking if we would allow a nurse to come into our home and have a home health visit. And Mark and I were both in agreement that we didn't want any additional middlemen inserted between us and our doctors. So we said no. And I didn't realize at the time that United Healthcare was positioning itself to upcode our medical diagnoses. Upcoding is a systematic method to drain our Medicare trust fund. It's fraudulent, and it lines the insurance company pockets with profit. In 2022, we also learned that since we had signed up for Medicare Advantage, we were eligible for what Medicare calls a guaranteed issue. We could switch back to traditional Medicare that first year, and that guaranteed issue saved us from an underwriting evaluation, which would have resulted in higher costs to us as consumers. So both of us switched back to traditional Medicare. So I'm going to talk a little bit about traditional Medicare and Medicare Advantage. Traditional Medicare started in 1965, and it's very simple and efficient. And there's Part A, Part B, and no middlemen, nobody inserted between you and your doctor or you and your hospital. Then you have Medicare Advantage. Now, many of my friends who have Medicare Advantage absolutely love it. It started in 1997. People in general love their Medicare Advantage plan until they don't, until they've been diagnosed with a serious medical condition and they realize that high out-of-pocket limits, restricted networks, denial of coverage, and drug formularies that don't cover the drugs that they've been prescribed for their diagnosis all hit them. Then the Medicare Advantage plan isn't looking so great. It's complex, it's inefficient. Middlemen are inserted between you and your doctor and your hospital. And the middlemen are for-profit companies who become the profiteers. So Medicare Advantage continues to grow. For-profit corporations realize there's money to be made, and I mean big money. It's billions of dollars. It's about following the money. It's literally untapped. It's an opportunity for these middlemen to line their pockets, and believe me, they want a piece of the profit and they're going right after it. What kind of profit are we talking about? Well, the privatization of Medicare, if you look at traditional Medicare and the cost, out of every $1, 2 cents are spent on overhead, 98 cents are spent on patient care. Medicare Advantage, it's 85% of a dollar or 85 cents on each dollar goes to your care. but 15% or more goes to overhead and profits. So what kind of profits are we talking about? And how do they make these profits? Well, I'm going to talk to you today about one type of profit making that these corporations use, upcoding. I'm not going to go into other forms of fraud and deceit, but believe me, there are a lot of them. So upcoding, this is a practice that is fraudulent, and it's used by these middlemen to gouge more money out of the Medicare trust fund. And how do they perpetrate this fraud? Well, here we have a 76-year-old woman. Typical coding for her diagnoses would achieve a $9,000 payment from Medicare to Medicare Advantage, to the Advantage middlemen. But when the nurse comes to her home and talks to her, all of a sudden her obesity is upcoded to morbid obesity. Her asthma becomes COPD. Her ulcer becomes a stage 3 ulcer. So the diagnosis codes are increased. And guess what? Medicare Trust Fund is now paying her $32,000 for those upcoded charges. You know, it's mind-boggling, but what feels good to me is that we're starting to get a handle on this. Upcoding is getting the attention that it needs. The New York Times recently published a very good article. It was published October 8th of 2022, outlining the mind-boggling money that's being drained out of the Medicare Trust Fund. So I'm going to just talk about 1 year. This is a slide that shows in the year 2020, between 12 and 25 billion, and it's not million, it's $1 billion in that 1 year alone, was fraudulently taken out of the Medicare Advantage out of the Medicare Trust Fund, given to these middlemen. That's more than the budget at NASA. That's more than Children's Health Insurance Program. You know, you start to digest this and you realize the reason these middlemen are in this is to take those big bucks out of that trust fund. I could literally talk about Medicare Advantage, fraud, and abuse for another hour, but I won't put you through that. From a consumer's perspective, you now know you have protection under the law for your first year. If you enroll in Medicare Advantage and you are not happy, you can switch to traditional Medicare without the fear of underwriting and increased premiums. I want our children and our grandchildren to be able to understand and live with Medicare. I want our trust fund there for them. I want to stop the privatization of Medicare, and together, working together, we can do that. So at this point, I'll turn the presentation over to Dr. David Leibowitz to talk to you about the acceleration of Medicare privatization. Thank you.
David, you're muted.
And David, we should see your face too on a big screen at some point.
No, we have it.
Susie, do you need to unmute him?
No, he's unmuted now. Oh, no, he's not. David, you're muted.
He's trying to unmute himself, Marshall.
Oh, I see. Susie or Diana?
No, unfortunately, I could only mute. I can't unmute.
If he goes to the upper right-hand corner of his own framed picture of his face, he could unmute pressing those buttons in the upper right-hand corner.
Can you hear me now?
Yeah,
Yes.
yeah, good. Okay.
Can you see my screen?
Yes,
Yes.
perfectly.
Okay, great. We're in business. So, I think, yes. So I'm going to talk to you more about Medicare Advantage, what it is and how we ended up with it. It's a capitated health maintenance organization. People have to choose to enroll in it. You don't get automatically put into it. And the company running it gets a fixed amount of money every year. So it's a certain amount of money for each patient. But the important thing, as Deborah mentioned, is that the amount of money per patient is adjusted by the risk or the extent of illness for the average group of patients. So if a particular HMO has got patients that are more ill, they'll get more money per patient. There have been a variety of HMOs in Medicare since the 1970s. The theory has been the rationale for privatization in many areas, the idea that private companies will be more efficient and will save money while delivering equal or better care. That has never turned out to be the case. All the Medicare Advantage plans cost more per person than traditional Medicare. The popularity of the plans has gone up and down depending upon the specific rules from the Center for Medicare and Medicaid Services. Since around 2010, 2011, after the Affordable Care Act, there's been increased benefit for the Medicare Advantage plans. Now, this slide, you're going to see this slide in a number of different variations. Deborah showed you the first two pie charts. This basically shows the transition into more and more profit from traditional Medicare to Medicare Advantage to this third entity that Dr. Malinow will talk about, which is the ACO REACH program. So as Deborah mentioned, traditional Medicare has an overhead of only 2%. The reason Medicare Advantage is popular with profit-making insurance companies is that the overhead or the profit can be up to 15%. Now, how do they get that profit? So in the Medicare Advantage setup, you've got Medicare, the government agency. They send a certain amount of money to the HMO. And that amount of money, again, depends upon the number of patients and how ill they are. And then the middleman or the intermediary sends a certain amount of money to the doctor. Now, how does the middleman make a profit? They maximize the amount of money that's coming in and they minimize the amount of money that's going out. So the less care they provide, the more profit they get, and the more money coming in, since they're getting a percentage of that money, the more money coming in, the more profit they make. So what are the different ways that these companies cheat? Well, fraudulent coding is one of the major ways. This is the upcoding that Deborah mentioned. And as she showed, this makes an enormous difference in terms of how much money the companies get. They also restrict the doctors that you can go see, so that if you have a particular illness and you might like to go see a specific specialist, you can't necessarily do that because they have a network of doctors. They limit the medications that are available. So if there is a particular medication that would be best for you, but is very expensive, it may not be in their formulary. Prior authorization is another real racket they have going. Since it's an HMO, they can insist that you have prior authorization before procedures or before referrals. And they do that a lot. And one of the studies showed that if you look at the denials of care in Medicare Advantage programs, more than 90% of those denials would be approved if you used the traditional Medicare criteria. Another thing they do is they try to get rid of sick patients. This is called lemon dropping. And it means that if someone becomes ill and needs expensive medications or treatments, they'll deny them. And another thing, and this, there's been a lot of examination of this question, but it appears that the companies try to enroll a healthier group of patients, and this is called cherry picking. Now, Deborah showed this article. This is a great article to look at. It will tell you a lot about Medicare Advantage. It was in the New York Times, October 9th of 2022. And it got quite a lot of publicity. It has contributed to all the negative publicity for Medicare Advantage. And it's a really good thing to look at. I'm going to show you a couple of examples. So this is looking at the profit margin. And it's over 2018, 19, 20, and 21. And the bars are the individual market for insurance, the group market, the Medicaid managed care, and this big tall blue bar is Medicare Advantage. And what you can see is that particularly after 2018, there's been a lot more profit for these companies from Medicare Advantage. That's why they are so excited about this program and why they wanted to continue. This next slide is very similar. What it's showing is that the Medicare market, this is for United Healthcare, which is the single largest Medicare Advantage program. Their income from their private insurance has been pretty stable, but their Medicare income, this is going from 2010 to 2021. The Medicare income is just going up dramatically. Now, again, how are they doing that? Well, this is looking at fraud. This is listing the 10 major Medicare Advantage providers. And then we've got different ways in which they have become accused of fraud. Some of them from whistleblowers, some of them were accused of fraud by the government, and some of them were accused of overbilling by the Inspector General within the Medicare program. This shows that they're basically bribing doctors to change diagnoses. This is looking at 6 of the Medicare Advantage programs, and 3 of them give doctors additional money if they add diagnoses to patients. Again, this is upcoding, and it increases the amount of money that the program gets. Now, quality of care has been a difficult thing to look at. This is an example from oncology, and because it's something I'm familiar with, I was very struck by it. This list is a list of major cancer centers. This study is looking at where cancer surgery has been done. Basically, this is looking at the ratio between traditional Medicare patients and Medicare Advantage patients. And on this side of the line represents having a smaller fraction of Medicare Advantage enrollees. So basically, if you're in Medicare Advantage, you're much less likely to have your cancer surgery at one of the major cancer centers. That's a very significant problem because it has been shown many times that surgical outcomes are better when they're done at centers that have higher volume, where the staff is more experienced with the procedures and where they know the possible problems. So this is clearly an example where Medicare Advantage enrollees are basically getting shafted. This is my last slide. It's again just reminding you of the way in which these companies are maximizing the money they pull out of the trust fund. Again, fraudulent coding is a major issue. The restricted network of doctors, for instance, not allowing patients to have cancer surgery at major cancer centers, limiting the medications that are approved, requiring patients to get prior authorization, so delaying procedures, and then again, lemon dropping and cherry picking. So those are the things I wanted to say about Medicare Advantage. Now, Dr. Malinow is going to take us through this third alternative, ACO REACH, which is even more parasitic. So I'll leave it to Anna.
Thank you, David. I think you're still sharing your screen, or not?
Can you can one of the moderators turn that off? Because I'm let's see. Oh, here.
Okay, no, I'm good. I'm good. I'm good now.
Now you're good.
Yeah.
Yes, I can see it.
All right, great. Well, let me turn this on. Do the slideshow. Oh, let me see. Back. Great. Well, thank you, David, and thank you, Elsa, for inviting me, and Susie and Diane. Also my co-panelists, David and Deborah, and the San Mateo County DFA for putting on this program for us to talk about the privatization of Medicare. I will talk mostly about ACO REACH, this program called ACO REACH, which I believe is a threat to Medicare, and how we can actually reverse the privatization of Medicare. I'm going to minimize this a little bit here. All right, great. So my only conflict of interest is that I am past president of Physicians for National Health Program. My views, however, are my own and do not necessarily always represent PNHP, but I do thank PNHP for selected slides on this deck, and those slides are attributed to PNHP. So we've already heard about quite a bit about Medicare Advantage, but what I'm going to be talking about tonight is a program called ACO REACH, which stands for Accountable Care Organizations Realizing Equity, Access, and Community Health. ACO REACH was formerly known as Direct Contracting Entities, or DCEs, and they are using the exact same Medicare Advantage playbook to increase their profits, just like what Dr. Leibowitz was talking about. ACO REACH threatens to privatize traditional Medicare by inserting for-profit middlemen between beneficiaries and their doctors. So we're going to see the difference between Medicare Advantage and ACO REACH is actually quite minimal. And finally, and that ACO REACH is threatening senior choice, medical care, and solvency of the Medicare Trust Fund. The last thing we were going to be doing is just talking a little bit about what we've done so far to oppose ACO REACH and what we still need to do in order to stop this program. So I like to think of Medicare like a pie. And before 2003, you can see that most of the beneficiaries were signed up for traditional Medicare. Now that's the green piece of the pie, and you can see that the vast majority chose traditional Medicare as opposed to Medicare Plus Choice, which is what Medicare Advantage was called before 2003. Now, traditional Medicare has in it the Part A that covers 100% of hospital costs, Part B that covers 80% of outpatient costs, Part D, which covers your prescription costs, and then the supplemental plan, which I think somebody asked about, which is the Medigap, that covers 20% of the rest of the 80% that the Part B doesn't cover. So this is what the Medicare pie looked like before 2003. Now let's fast forward to the Medicare pie today, and you can see that just about half of the members have chosen to enroll in Medicare Advantage, and the other half, or about 30 million beneficiaries, are in traditional Medicare. Now, as David was mentioning, there's a lot of money at stake. In fact, the total projected budget for Medicare for 2028 is $1.6 trillion. Now, Medicare Advantage has already privatized half of Medicare. You can look at the pie right here, and the red slide, the red piece of that pie, the red slice, is Medicare Advantage, which is the privatized part of Medicare now. But these plans are looking, these corporations are looking at the other side of the pie, the green slice, and saying, wow, there's there's more than half $500 billion here at stake. And how can we get that bit of the pie as well? So what I'm going to be talking about is traditional Medicare and the threat that ACO REACH poses to traditional Medicare. Remember, these are individuals that have rejected Medicare Advantage and have chosen to remain in traditional Medicare. And this is what is under threat today. Now, most people have not heard about ACO REACH. So if you haven't heard about it, don't feel bad, because until very recently, most people hadn't heard about it. Most seniors, most members of Congress hadn't heard about it. It started as a stealth program under the Centers for Medicare and Medicaid Innovation, which is under the CMS, which is the Centers for Medicare and Medicaid Services. And it started as something called direct contracting entities, or DCEs, under the Trump administration. And just like Medicare Advantage, it inserts a for-profit middleman, not called Medicare Advantage, but now called ACO REACH, that accepts the capitated upfront fees, right, to share the risk to provide care for seniors on traditional Medicare. So we're just talking about that green slice of the pie right now. And that is what is being privatized by ACO REACH. Now, under traditional Medicare, remember that Medicare pays the providers, the doctors and the hospitals directly. So you go to your doctor, if you're on Medicare, doctor provides certain services, the doctor bills Medicare for those services, and that Medicare pays the doctor directly. There is no middleman there. However, remember, this is the slide that Dr. Leibowitz showed you about Medicare Advantage. Well, under ACO REACH, it's very, very similar. Medicare pays middlemen that are now called ACO REACH to share the risk, the financial risk of providing medical care to patients. And this is a capitated upfront fee that first goes to ACO REACH. And as you can see, the first bar, the first arrow is big, and the next arrow is much narrower. And that's because the ACO REACH decides how much care that patient is going to get. Now, we went from traditional Medicare, where Medicare pays the doctors and hospitals directly, to Medicare Advantage, which inserted a middleman between Medicare and providers, to ACO REACH, which inserts another set of Wall Street investors who are absolutely flooding ACO REACH middlemen with new money because they expect big profits. So now, what are these ACO REACH companies, right? Well, virtually any type of company, regardless of healthcare experience, can apply to be an ACO REACH, including commercial insurers, Medicare Advantage plans, private equity firms, venture capital investors, other accountable care organizations, physician private practices as well. And all of these applicants are approved without any input from Congress. Now, how does ACO REACH make money? Remember how Medicare Advantage made money? Well, very much the same playbook. They maximize the revenue from Medicare, right? They use things like upcoding and cherry picking and lemon dropping. They want to get as much money as possible from Medicare. And then they minimize the amount of money spent on beneficiaries through denial and delaying care and creating narrow networks so that they can keep as profit and overhead what they don't spend on medical services. This creates a dangerous incentive to ration and restrict care for seniors and people with disabilities on traditional Medicare, threatening their medical care. Now remember, these financial incentives do not exist in traditional Medicare. And why? Because there's no middleman in traditional Medicare siphoning off profits, as opposed to Medicare Advantage and now ACO REACH under traditional Medicare. Now, this is the same slide again. I guess we're beating you over the head with it, but ACO REACH is threatening the solvency of the Medicare Trust Fund. Again, look at on the left, if you just concentrate on the green part of the pie, which is patient care, 98 cents of every dollar goes to patient health care under traditional Medicare. Under Medicare Advantage, It's 85% goes of every healthcare dollar goes to pay for healthcare needs. And under ACO REACH, as little as 60% will go to patient care. And that's because ACO REACH will be able to keep anywhere from 25% to 40% of that healthcare dollar for administration and profit. Now, the big question becomes, how do you enroll millions of seniors and people with disabilities into ACO REACH? Well, you don't tell them. And as a result, over 2 million seniors and people with disabilities on traditional Medicare are being automatically enrolled, or aligned as they call them, scooped into an ACO REACH without their knowledge or consent, threatening their choice. And how are they doing this? They're doing this through their primary care provider. Because unlike Medicare Advantage that tries to recruit as many seniors as possible during open enrollment, or during open season, as I like to call it, right, with those incessant ads, ACO REACH does not do that. What they do is they lure physicians to sign up into an ACO REACH. And once a senior's PCP has joined or is owned by an ACO REACH, Medicare will then automatically align or scoop up that senior into that ACO REACH without the knowledge or consent of the senior or person with disability, meaning that if your PCP now belongs to an ACO REACH, that whole panel of patients that PCP has automatically gets dumped into that ACO REACH without necessarily the senior being aware of that. And the only way to opt out is to find another PCP, another primary care doctor, which, as we know, is not an easy thing, even in the Bay Area. So what's next for seniors? Well, according to CMS, the Centers for Medicare and Medicaid Services, that's 30 million Medicare fee-for-service, meaning traditional Medicare beneficiaries, will be in a care relationship with accountability for quality and total cost of care by 2030. This is from their website. Now, what does a care relationship mean? A care relationship is a capitated shared risk payment model, just like the middleman, which is Medicare Advantage, and the middleman that ACO REACH is. And so they might call it something different, but by 2030, every single traditional Medicare beneficiary is going to be in some kind of a capitated shared risk payment model by 2030. So that means the wholesale privatization of Medicare, because one half is already privatized. We saw that, right? The red piece of the pie is already privatized. And now the green piece is slowly being privatized. And by 2030, it will be fully privatized. Now, what's next for California activists? Well, lots of resolutions that we can pass against ACO REACH. Now, let me just let you know that nationwide, over 300 organizations have signed letters opposing ACO REACH, including over 40 unions and 6 ARA chapters. And for those of you not familiar, that's the Alliance for Retired American Chapters, including CARE, which is the California Alliance, and most recently Texas. So what we're doing in the movement to end privatization of Medicare is we have a three-pronged approach. Number one is we're working with California Democratic County Central Committees. And so far we have 19 that have passed resolutions against ACO REACH. We have sent a resolution against ACO REACH to the Resolutions Committee with the strategy that the California Democratic Party will pass a resolution opposing ACO REACH and come out publicly against ACO REACH during their state convention in May 2023. The other prong, the second prong, is we're working with California Central Labor Councils. And so far we have 5 that have passed resolutions against ACO REACH, again, with the strategy that the California Federation of Labor will pass a resolution during their legislative conference in May of 2023 as well against ACO REACH. Now, how do we stop REACH? And this is where our action items come in. One is you can pass a resolution in this group, and I will be very happy to share my PowerPoint presentation, and you can go to this link and you can find the template for the resolution that was submitted to the Resolutions Committee. Or you can pass a resolution in another group. For example, if you belong to a Central Labor Council, to a union, to a Rotary Club, or whatever, you can use another template for a resolution to stop the privatization of Medicare through ACO REACH. And then our third prong is you can work with your member of Congress. Now, there are 21 California Congress people who belong to the Congressional Progressive Caucus. And I'm going to show you a list in a minute. But there's a link here on how to speak with your member of Congress. I'm sure many of you have already done this, so you don't need to look at the tips. But there is a cover letter there, if you use this link, to reach out to your member of Congress to talk to them about ACO REACH and the privatization of Medicare and how you want them to stop ACO REACH. And really what we want them to do is for your member of Congress to send a letter to HHS Secretary Becerra or CMS Administrator Brooks LaSure to tell them to stop ACO REACH. And so you can find that letter by going to the link. And it's a letter that we're hoping that you can convince your member of Congress to send to Becerra and Brooks LaSure. And then finally, you can learn more about ACO REACH by going to this website. It's protectmedicare.net, where you can find lots and lots of important information. Now, if you see that your member of Congress happens to be on this list, other than Mark Desaulniers and Jared Huffman, whom we have contacted already, please reach out to them, because these members of the CPC are not hearing enough from their constituents, and they need to hear from their constituents to stop ACO REACH. So thank you very much, and I'll be very happy to take questions.
Could I start with one question right away, which is, David,
Well,
I know that you have.
Wait, Elsa, let me put up the ground rules for Q&A, please.
Okay.
So, as Marshall did, would you please go to reactions and do a raise hand to get yourself into the queue to ask a question? And then we'll take them one by one. And I also am going to want to come after you get started. I would like to have some of these chat discussions also included, because I think we've had some good questions in chat. I want to make sure the whole group is seeing that chat and hearing that. So Elsa, I'll let you go ahead.
Sorry to Marshall. Two things. So David, I thought that you said that Kevin Mullen was supporting Medicare for All. Have you talked with him also about ACO REACH? He's one of our Congress people. He's yours also, I realize. Have you talked with him about, you have talked with him about
Yeah, we did talk with him about
Is
ACO
he
REACH.
is he not pushing back on it? I mean, pushing back to Becerra?
Well, I have not heard what his response was. We talked with his healthcare chief of staff and we gave him the letters, but I have not yet heard back from Mullen about whether he's going to send them. And it looks as though he's not yet a member of the Progressive Caucus.
We can work on that. Is there something specific that we
Elsa,
can do? Do we call them?
One question, putting back into the queue now. Okay, Marshall, you're up.
Thank you. Great, clear presentation. Thanks all three of you. That's wonderful. And with regard to Kevin Mullen, we can contact him directly also. We have a good relationship with him, and he promised to strongly support Medicare issues before he got elected to us. But my question is, it seems to me that Medicare Advantage, one of their main selling points is that they provide benefits for eye care, and I think hearing and maybe even dental, I don't know. But it would seem to me that that's a main selling point for them. So are they one of the main groups that is fighting against Medicare, including those benefits?
I think that's correct. And the other thing that makes them very attractive is that they are the least expensive. So that for people who have limited incomes, the programs look very attractive. And as long as the people are healthy and never need any expensive treatment or expensive medications, they'll be fine.
Yeah, if you're well, you don't need any of those.
Exactly.
Thanks.
Okay. Next up is Greg.
Am I muted?
Nope, you're good.
Good. My comment was very similar to Marshall's. I spent my whole career and life at the Palo Alto Clinic, and I never joined any of these extra programs because I didn't trust them. But as Marshall said, and Dr. Leibowitz just confirmed, it looks like they're enticing people to join these programs because of completely different things, which they would never admit to this fraud. But what I don't understand is how can we avoid that fraud with a resolution? A resolution doesn't apply to them directly. Who is the main person in the government that has to say no to them?
Well, I think I can answer that. That's a really excellent question. Who do we go to in the government, right? And you would think it would be CMS, the Centers for Medicare and Medicaid Services, because they have been given the stewardship to look and to protect Medicare, but they are not. They really, really are not. Unfortunately,
Why aren't they?
Why? Well, because there's this thing called a revolving door, and many of the appointees in CMS come straight from the industry, and so they protect the industry much more than they protect the beneficiaries.
But
Unfortunately,
how can they protect fraud? This is terrible.
I know.
I know it's hard to believe, but they do. In fact, CMS had just come out with a proposed rule where they were going to go after these Medicare Advantage plans for fraud, for defrauding them of billions and billions of dollars. In 2022 alone, I think it was like $25 billion. And the industry put up such a fuss that CMS decided that instead of passing this rule for next year, they're going to give the industry 3 years to think about it and to mull it over, and for us to forget about it. So unfortunately, that's just the way that things go and how they function. And then as far as to answer your question about the resolutions, you're absolutely right. We're not passing resolutions against the fraud and Medicare Advantage. We are not doing that. What we're doing is we're passing resolutions to put an end to ACO REACH in traditional Medicare, because we do believe that this is a winnable fight. And actually, President Biden could end ACO REACH tomorrow with a stroke of a pen. So that is something that we need to consider. And that's what I believe these resolutions that would get the Democratic Party to go on record, the California Democratic Party to go on record against ACO REACH as other states have done, like Texas and Washington, for example, and to get the AFL-CIO to go on record publicly against ACO REACH and putting pressure on President Biden to sign an executive order ending ACO REACH.
But that's not enough. You need to make upcoding illegal.
Yes,
Absolutely,
right.
you're absolutely right. It needs to be illegal, and they shouldn't. The middlemen shouldn't be able to settle, because when they settle, they're not admitting to wrongdoing, and they're allowed to stay in the program. So those are other changes that need to be made, and we can continue to talk to our members of Congress about it, because they are running CMS without congressional oversight. So if we can get Congress involved and make sure that those practices are stopped, or the people that are perpetrating that fraud, the companies that are perpetrating that fraud, are removed from the programs, that would change the landscape considerably.
Thank you.
All right, we're on to Diana.
Sorry, I'm kind of embarrassed to ask this, but I got my Medicare through the school district that I worked for through all those years. And this last year, I was informed that the school district now has someone else that is handling their insurance. And so I thought nothing of it until this, until your report. So now I'm a little bit scared. And I also naively just signed up for Medicare Advantage because I had the impression that it made me eligible for more services or whatever. So is that not correct? And this I think it's called Navia. It's a like a self-insurance or something. It's a whole nother program that the school district signed all of us up for. So am I naively being taken advantage of here? I don't know. I'm
Well,
mumbling now, so.
you may very well be taken advantage of. There was just an enormous fight in New York City because they were trying to force all of the school employees into Medicare Advantage programs, and that was stopped in New York. I don't know the details of your particular organization, but as long as you're healthy, you're okay. The only problem is if you start needing any of the things that Medicare Advantage does not like to provide.
Right. Well, I do have generic medications, for migraine and stuff, but that never bothered me. I'm fine with that. I have Kaiser, and I've been very happy with Kaiser.
Yeah,
Then you
Kaiser is one of the more reputable groups. They've kind of fudged things also, but personally, I think that Kaiser generally has their patients' interests at heart.
I think
But
so.
again,
That's been my experience.
they have done fraudulent things.
Right, except for the fraud, they're fine.
Right,
The
exactly.
fraud, right.
Other than the fraud, no problem.
Okay. Well, thank you so much for bringing this to all of our attention.
All right, next up is Joan.
My question is for Anna. You had several things for us to look at, but they didn't have URLs, and we couldn't, click on them or anything like that. How do we get access to the things that you showed towards the end of your presentation that were, things that we can do, places to contact, et cetera, et cetera?
Excellent. So what I said was that I will make my PowerPoint presentation available to anyone. I can send it to Susie. In fact, I think Susie already has it. And I can send you an updated one because I made a couple of changes. But then Susie can make it generally available, I think, right?
Yeah, we can post those links on our website.
How about sending them also to those of us who are on this call who will know what it's all about and be looking for it? Whereas
the problem is, Joan, you're not a club member, so I don't have your address. So that's why I can post it on the website.
Even though I had to give it to get access to this.
But
yeah, I don't think I have that saved. Fortunately.
Then please put the website URL in the chat so that at least some of us will get it.
Okay.
Thank you very much for this.
You can also join for a very minimal amount, and then you are on our lists. You can also ask to be put on the list before you join.
And thank you. This has been really informative. I just started Medicare, and like Diana, I thought, Medicare Advantage. And I'm with Kaiser, so I thought, that sounded good. And so now I'm thinking, okay, I think I better make some changes. But my question is, you've been talking about ACO REACH. So if I go back to traditional Medicare, and I'm with Kaiser, am I going to end up on an ACO REACH program, which is worse? So I guess you were saying how people were getting automatically enrolled because of their doctors. Does that work when you're with a group like Kaiser, which already has their own set of doctors?
That's a valid concern, absolutely. If you are on Medicare Advantage, you choose that, right?
Right.
If you are on traditional Medicare, you choose to be on traditional Medicare, but CMS can very well put you into an ACO REACH if your PCP belongs to an ACO REACH, and they will do that without your consent. Mhm.
Yeah, that seems, frankly, that seems illegal that they can do that without your consent. And so.
Well,
All right.
unfortunately, there's a precedent for that, and that those are the original accountable care organizations that were created under the ACA, under Obamacare, and ACOs have been functioning for the past 13 years, and people don't necessarily know about being in an ACO. But you're absolutely right. Scary.
All right, and next up is Nancy. Jim? You're muted.
I think I'm unmuted now. This is Jim, and
There you
kind of
go.
a follow on because Nancy and I have been very happy members of Kaiser also for about 20 years. We did do the Advantage plan for a while and went back to just straight Medicare. I guess as a follow on to this whole thing, as Kaiser people, what do we need to do to protect ourselves, or where do we need to address this with Kaiser that we don't suddenly find ourselves in the ACO REACH program?
So I just need a clarifying question. You're still Kaiser Advantage then?
No.
No, it's
Or
straight
you're
Medicare.
in traditional Medicare?
Yeah.
Well, if you're in traditional Medicare, you are not going to be taken over by Kaiser, because Kaiser does not do traditional Medicare.
Oh, I guess we thought we were in traditional Medicare. We're not in an Advantage plan.
But you're under Kaiser? You're under Kaiser? I'm a little bit confused. I don't know. You're muted. You're muted.
And what's the difference?
We have straight
Kaiser
Medicare
versus
under
Medicare?
Kaiser,
I'm sorry?
straight regular Medicare under Kaiser. What do we need to do?
I don't know. I don't know if Kaiser is an ACO. I kind of doubt it. I don't know. David, do you know? Or Deborah?
I don't know either. I think that many years ago, there was another way to enroll in Kaiser with Medicare. But I don't know whether, I mean, they used to have a Senior Advantage program, which I assume was a Medicare Advantage program. But I really don't know how Kaiser works with Medicare right now. I also would doubt that they would set up an ACO REACH. It wouldn't be any benefit for them.
Yeah, and I've got to say, I don't have any personal experience with Kaiser either way on Medicare Advantage or regular Medicare, but you've raised a very good question. And I think we will look into that. I know I will try to find out a little bit more about it.
Because Kaiser is a major provider, certainly in the Bay Area.
Right,
Yes.
right. And what happens is that people start on Kaiser when they're newborns, right? And they go through childhood and adolescence and then young adulthood, and then they're working and they stay on Kaiser. And then when they retire, they stay on Kaiser because it feels familiar. They've had a good experience. You know, they've been healthy, they've been working. They have their PCP, they know the system. And so most people in Northern California that start with Kaiser end up with Kaiser Senior Advantage. Yeah. And most people are happy with the program.
Yeah.
And Kaiser is not a traditional for-profit business like these other are. They do not sell stock.
It doesn't mean people don't make money off of it.
Yeah.
Yeah, not for profit doesn't necessarily mean that you're not making a profit. Yeah.
All right, let's move on to Mike.
Yeah, I feel there's a bit of confusion because I've had supplement, what do you call Medicare supplement, advert rather than Advantage, but that's the 20% that the Medicare doesn't pick up. So it seems like there's a lot of confusion of what about the other 80% that's under Medicare? Is that also being moved over into some of these Advantage programs, or are we just talking about the 20% that the supplements are recovering?
If you're paying for a supplemental plan like Medigap, that means that you're in traditional Medicare, that you have Part A, Part B. As I said, Part A covers 100% of your hospital costs. Part B covers 80% of your outpatient costs. And that's why you get a supplemental plan, which is a private plan to cover the 20% that the Part B doesn't cover.
Okay, because it seems like I'm paying about $400 a month for that,
Yeah,
just for
it's
the
not cheap.
supplement. And you're going to have one hell of a time trying to get people to say, oh, I'd rather pay $400 rather than the $100, which what is it, United Healthcare, and they send you a free scale and do all kinds of, obviously they're getting their cut, not from you, because they're giving you a kind of a reduction in a sense, but they're enabled to play their whole game and get the rid of the money from the other end, from the government.
Right.
Which, if that's not made clear to people, they're going to fight you to death saying, oh, you want me to pay $400 rather than $100. Oh, that's a great idea. And then I'll lose my vision and my hearing. I mean, luckily I have my VA as well. So I play that game too, but I make too much money to have it free. But I kind of act my primary care is actually a VA person. And I generally go there for a lot of my care. But it just seems like without making a big issue of the bogus billing and the fraudulence, you're going to never succeed, because people will be saying, oh, you want me to pay $400 rather than $100? That's a great idea. They won't see that, oh, wait till you get sick and then you'll learn. Yeah, that's not going to work. That's not going to sell. So I think you've got to, that's why I put in the thing about consumer reports. You think they'd be all over this? What about the Inspector General? They'd be all over this.
Well,
they should see per capita that they're paying a hell of a lot more for the people that go with these bogus plans than they're paying for the people that are not in them. I mean, they should, their brains, what's going on? I mean, they should be making a public statement saying the Inspector General says you're raping our Medicare trust fund because of X, Y, and Z, and that's got to be job one. If you don't succeed there, you're succeeding nowhere. That's all I have to say.
You're right.
Okay. All right. On to Elsa.
Thank you. I just got a month ago a notice from my doc saying, my doc's, clinic, whatever, saying, oh, we're now an ACO and you can choose within this segment of docs and everything. I thought, oh my God, and went right straight to him. I have no idea what you're talking about. You've got to go. Isn't there a phone number you could call? So that was a great experience, which is still on the way. The question I've got is, you mentioned taking this resolution to CADEM, to the California Democratic Party, for the May convention. And a number of us, me included, are delegates at that convention. I'd love to know, how close do you think you are to getting it passed? And what can we do to help lobby people to try to get it passed? Do you have any idea how close you are?
Well, we just sent a resolution to the resolutions committee and as I said, we have 19 county central committees that have passed resolutions against ACO REACH. Now there are 55 county central committees, and so that's not quite half yet. That's our goal. Our goal is to get to half. So we have about 7 or 6 more in the pipeline, and Deborah can talk more about this as well. I think that the more central county committees that we can get to pass resolutions against ACO REACH, the greater the likelihood that CADEM will pass a resolution during their convention. So for anybody here who's also part of a central county committee, please let me know or let Elsa know, or Susie, and then you can get in touch with me or Deborah.
And 3 people here are.
And I would say, oh, go ahead. Go ahead, Anna.
No, I just want to know which ones.
The next speakers, Gregory Lowe, Ashley Evans, and Diana, who is somewhere here. And she's down on the 3rd row. Diana Reddy are all voting members of our DCC, none of whom think that they have been asked to pass an ACO REACH resolution, although we have heard from you that their DCC, our DCC has passed it. So we're...
I really don't think so.
I'll go look at the spreadsheet while you're talking right now.
Not only do I not think so, but I didn't even know what ACO meant. So I wouldn't have voted for something that I wouldn't know even what the meaning was.
But we would like to have you speak to them next, just FYI. Which you'll
Okay.
hear about shortly. Greg.
Let's move on to Greg's question.
Well, my question is really a complaint. I cannot believe that it took so many years for the New York Times to write an article about this. This is this upcoding and all the other derivatives of it. It's a scandal. How was that kept secret?
So it has been kept secret. Congress has been appraised of this for, I would say, at least 2 decades. They get reports from the OIG, from the Office of Inspector General, going back to, I forget who it was that just had that great question and they get great comment, to the Office of Inspector General, to MedPAC, to the Accountability Office. Congress has been receiving these reports regularly, year after year after year, letting them know how Medicare Advantage has been defrauding Medicare, either through upcoding or cherry picking, risk adjustment, and every other way, that lemon dropping, denial of care. So there is nothing new, but what you're absolutely right is, why did it take the New York Times 20 years to write this story? That's a good question.
And I was going to follow up with that and say a very good book to read is The Privatization of Everything. It's by Donald Cohen, and he was a speaker at the Physicians for National Healthcare conference in Boston in November of 2022. It was his speech that made me read the book to understand there's a movement going on. So mainstream media is not going to report this kind of fraud, because there's a movement going on to privatize literally everything. Medicare,
Social Security.
And Social Security is right up there with it. I mean, we were just down at Kevin McCarthy's office in Bakersfield protesting against the privatization of Social Security and Medicare. They're both on the docket. So that's why mainstream media won't pick it up and they won't cover it. And I was quite shocked that, frankly, that the New York Times actually put something out. I think the problem is getting to be too big to cover it up anymore. Too many people are finding out about it, the extent of it. It's not millions, it's billions of dollars. And when you start to look at how big it is, they're derelict in their duties and responsibilities. But, you know, that's a whole nother meeting, the getting money out of politics.
That's the issue. What companies pay for their election campaigns.
Yeah.
We're running out of time, so I'm going to go to Ashley and then Gail.
Okay.
And Elsa, I'm going to cut you off and say we're going to be done after Gail.
Okay.
Yes, I was shocked recently to see that Sutter Health, I happen to be in their system. Peninsula Hospital is my hospital. I have, in the last decade, been really getting my money's worth out of Medicare. And so I love Medicare. But I saw recently Sutter Health has started advertising that they are offering their own Advantage plan. Medicare Advantage plan. And I was shocked at that. I started thinking about the ramifications of that, of how if they are now in it for the money, if they'd been in it for the money 2 years ago, I wouldn't be here, you know? So it's very concerning to think that if they get into this privatization program, that they will start denying care. I am shocked by this, and I'd like to know how widespread this is, and why a system that I believed in is doing this. Okay, I know why they're doing it, but
Follow the money.
yeah, for the money.
Yeah, I mean, Sutter recently settled for $90 billion for defrauding Medicare.
Oh, my goodness.
Yeah, that gives you some insight.
$90 billion?
No, sorry, 90 million, 90 million.
Oh,
I'm sorry if I said
Oh,
billion.
just peanuts.
Sometimes, no, 90 million.
okay. We're going to take one last question from Gail, and then I've got to cut it off because we're out of time.
Okay. And I want to say I did look up San Mateo County on Ruth Carter's spreadsheet, and we've got a contact person of Alan Cooper, and it states resolution adopted. San Mateo County.
No, we don't have
Yes,
Alan Cooper.
We don't have an Alan Cooper.
Alan is not on the San Mateo committee. He's in San Francisco, but he has said that he had some contact person in San Mateo.
Oh, well, that may be true. But
Okay.
he hasn't contacted us though.
I don't know who it is that he speaks with.
Okay.
Okay. I'll
Good, thank
follow
you.
up on this. Thanks.
Thank you.
Sure.
All right. Gail, did you still want to ask a question?
Yes,
And you're the
I
last.
was, it's kind of a personal question, but if a doctor's in a big institution like Stanford Clinic or Stanford Family Practice, can individual doctors decide to join, or would it take a decision to take the whole clinic in that direction?
That's a really great
one of those
question.
awful programs.
That's a really great question. And it's typically not the individual doctors making individual decisions. It is the leadership that's making the decision for them.
Right.
There
And I
was a
know there's-
physician, there was a physician in Indiana who tried to refuse being put into one of the groups. And I'm not sure what the resolution of that has been. At one point, it looked like he might be succeeding, but I don't know.
Well, yeah, so we had him speak at one of the national single payer webinars, and it looks like they gave him a 1-year reprieve from joining an ACO REACH, despite the fact that the entire practice joined ACO REACH, or was forced to join ACO REACH, but it's going to be revisited next year.
And he was made persona non grata.
Yeah. I mean, yeah.
Well, I want to thank you, Anna and David and Deborah. It's been
Thank
a
you.
marvelous. We still have so many questions, and we could probably go for another 2 hours and still not answer everything. It has been marvelous, and I think we all have a lot to think about. And I really, really appreciate your coming to talk to us tonight.
Thank you so much.
All right. Thank you, everybody. It's been a pleasure.
Bye.
We'll
Bye.
do a follow-up because.
Thank you. You guys were great.
Thank you, Elsa.
All right.
Bye.
Okay. Okay, sorry about that. So I'm going to move on in our agenda. We've got a couple business items to talk about tonight. And the first one is going to be bylaws. We are required by the State Democratic Party to make some changes to our bylaws. And And Ashley, I'm hoping you can kind of guide us through this. I can
Okay.
put it up on the screen.
Okay, yes. We are a chartered club under the San Mateo County Central Committee, Democratic Central Committee, and they are a chartered organization under the California Democratic Party. So we have been given by the California Democratic Party something that they insist, it's mandated that we put it into our, specifically address this issue in our bylaws. We have in our bylaws already that we follow their rules and their bylaws. So it isn't, you know, they want it to be specific though, and we really have no choice. But it also says in our bylaws that we make no changes to our bylaws without a vote of the membership. So we're bringing it before you. And, you know, although as I'm telling you, we really have no choice. We also have no choice but to get your okay. It's a very minor change. It comes under rules that govern the California Democratic Party pre-endorsement conferences, which is it's kind of complicated, and it affects us very little because we're a small club. It has to do with qualifying delegates to these pre-endorsement conferences. And so where our old, you see there are current bylaws under affiliations. So the affiliations deals with our affiliation with both the Central Committee and the State Committee. And so what we had before is there. And to that, we have been asked that not only they are addressing the fact of when they want us to submit rosters of our membership to qualify delegates to go to these pre-endorsement conferences. So we added just a sentence to the beginning of this, the proposed change that identifies that the list we submit to them has only members of good standing, and that we list them as being members in good standing by a certain date, which they will give us every year. At first, we thought we had to put the year, thought we had to put 2023 into it. But then we have found we don't have to be that specific. We just say we will pick the date that they choose for us. So as I said, it's perfunctory. You all can see it. I don't think you need me to read it to you. Is that correct?
Yes.
So I make a motion that we adopt this amendment to our bylaws.
I'll second that motion.
Okay, is there any discussion?
I'd like to call
Please
the
raise,
vote.
I'm going to say, please raise your hand if you have anything to discuss on this. I can't see everybody in the. Seeing there's no discussion, shall we go ahead and put it to a vote?
Yes.
All those in favor, if you would please raise your, I'm going to close mine, and please raise your hand using the reactions button, or physically raise your hand. That's okay.
And those who can vote are members in good standing. So
Right.
if you have to have paid up dues.
Oh, yeah, I've got mine. Okay. All right. I think we've got a a good group there. Thank you so much.
Well,
That
wait.
was our,
let's
Any
hope-
opposed? Any opposed?
oh, thank you. Thank you.
So put down your hands. And then we'll go to the opposed.
Okay.
All right, passed. Thank you.
Thank you very much. All right. On to our second bit of business. I'm going back to Ashley again. We have the annual election of officers, club officers. Ashley.
All right, it is April, and so we are doing our annual election for club officers. The officers' positions are chair, vice chair, program director, secretary, and treasurer. Can you put our current office holders are Chair Susie Ray, Vice Chair Marshall Dinowitz, Secretary Diana Reddy, and Treasurer Casey McClure. My first question, are all these incumbents running again this year? Susie? Okay, Marshall?
If no one is opposing me, I mean, I'd be
Well,
happy to-
just, are you
We
in,
have to get there.
are you interested in the position? Okay, Diana?
Yes, we should make it clear that if no one else wants to step up, we are interested in the position.
Okay, Casey? Is Casey? still-
You're muted,
so,
Casey.
Casey.
Yeah, there she is. Okay, so we sent out a notice to the membership, notifying them about this election and inviting them to submit applications. And as elections manager, I was the one to receive these. I didn't receive any applications. However, you can throw your hat in the ring right now if you would like to. Is there anyone who would like to run for one of these offices? Please raise your hand. Oh my goodness, so many hands.
I'd be happy to catch any hats that come into the ring.
Can I just move we approve that slate?
Okay, yeah, there seems to be no acclamation, no opposition. So let's take a vote to re-elect these current officers by acclamation. Those in favor, please raise your hand. Okay.
Marshall, how about you?
Unanimous.
All right, now you can put your hands down. Those opposed? Okay, only Marna, Joanne, and okay, hands keep coming down. Okay, so by acclamation, we will return these fabulous stars to their
Oh,
positions as
good.
our club officers.
Thank you.
Congratulations.